Good evening, everyone. On behalf of BioT, I am Nancy Pagan, the District Manager in the Northeast area for BioT. Tonight, as your moderator, we'll delve into the remarkable benefits of peptide therapy. Before we begin, I encourage you to direct your questions to the right-hand side of your screen. At the conclusion of our presentation, we will address all questions. And now, without further ado, I am delighted to introduce tonight's presenter, Dr. Eric Joseph. He is not only a certified hormone replacement specialist, he is also a peptide expert and also a pioneer in changing the landscape of the way medicine is practiced in America. Dr. Joseph, the floor is yours.
Well, Nancy, with an introduction like that, I have to say thank you very much. And thanks as always for helping us with these webinars. I think everybody that's out there that's watching in some way, shape, or form has heard of a GLP-1, those weight loss medications that are seemingly inundating the television waves with commercials with brand name products and compounded products, and what should you do, and some of your friends may be taking these medications. And I want to try to shed some light on GLP-1s or glucagon-like peptides. Why do we prescribe them? How we use them in our practice to enhance your health by changing your body composition or by losing fat mass and gaining muscle mass. I thought it was ironic that while I was preparing for this talk last week, these are screenshots from my cell phone from realself.com. Which is better, Ozempic or Mounjaro? Trending. More interesting for me from Medscape on November 9th on my inbox are GLPs, the newest form of fertility treatment. Obesity drugs versus surgery, similar results. Can we repurpose obesity drugs to reverse liver disease? And the very timely article, are ultra-processed foods driving the obesity epidemic in America? I say yes. So certainly Ozempic and Mounjaro, which are semaglutide and tirzepatide, they're definitely in the news all the time. You can't help but see them. So what are they? They're peptides. Well, what's a peptide? A peptide is a small piece of a protein, and peptides and proteins are made of amino acids. So in our diet, we consume carbohydrates. Our body breaks them down into sugars or glucose. We consume proteins, and our body breaks them down into amino acids. And we consume fat, and our body breaks them down into glycerol and free fatty acids. So those are the three things that we eat. And insofar as decreasing appetite and losing fat mass, I think that the GLP-1s are revolutionary, not just for that, but because of the added benefits that are starting to be read about and are being presented about today in the medical literature. So what are we made out of? The number one component of our bodies is water. 60% of our body is made up of water. So I wrote down, please drink more water. As a rough guide, everybody should drink 2 to 3 liters or 2 to 3 quarts of water a day. On that note, cheers. And it's so important. If your body is 60% made of water, this is why when if you're stranded on an island, you're going to die of dehydration before you die of hunger, because your body is just going to dry up. The next important component of our bodies, out of the water, protein, minerals, and fat, is protein. And the majority of protein lives in our muscles, and the skeletal muscles that wrap around the bones and of our skeleton and help keep us vertical and move around. That's the number one place where protein lives in our body, other than in our organs and skin and the like. The mineral and so how do we increase our lean muscle mass? Well, EDHP is exercise, diet, hormones, and peptides, where in general, if we want to increase skeletal muscle mass or protein mass, we want to increase exercise in the form of resistance exercise. When we change our diet, we want to focus on a high protein, high fiber diet that's also low in carbohydrates and low in fat. And when those aren't enough and we need a little bit more, when we meet, after a body analysis, we check hormone levels, and if hormone levels are okay, there's always peptides. The most important mineral insofar as our body composition goes is calcium. Calcium is mostly found in the bones. It's in 97% of calcium is in our bones. 3% circulates in the blood for a blood test. And calcium makes our bones hard. It makes our bones firm. Calcified bones are the opposite of osteopenic or osteoporotic bones. So calcified bones are strong. They're very white on X-ray because the X-rays bounce off of them as opposed to penetrating them. And so minerals is a big part, bones is a big part of our body composition. Then lastly, there's fat. Fat tends to torture most of us one way or another, but God gives us fat for a reason. Why is that? Well, number one, it insulates our body from loss of heat. It insulates our organs from a protective standpoint. And fat is also very useful during times of starvation. It's an energy source. So if two people are back to the deserted island, on a deserted island, and everything else about them are the same, except one of the people has more fat than the other, the one with more fat is likely going to live longer. So the goal with making your body composition as good as you can is to increase your skeletal muscle mass and to decrease your fat mass. And decreasing fat mass, believe it or not, is 80% due to diet and 20% due to exercise. So decreasing percentage body fat is where the GLP-1 peptides really come in and shine. Our goal is not to just change the number on the scale. I'm going to reiterate because I think these are really important. By increasing lean muscle mass, we are going to be a healthier version of ourselves. And by decreasing our fat mass, we're going to be a healthier version. Why? Well, first of all, how, before the why. Again, high protein, high fiber diet choices as opposed to high carbohydrate and high fat diet choices. And I put ChatGPT on here for a good reason. I'm really not a fan of artificial intelligence, but I really have learned to love ChatGPT on the iPhone and on the Android phone. Why? If you were to take one of your children's ChatGPT apps, or if you download the free app, it's a free app from the Apple Store. If you ask ChatGPT the question, what is a healthy grocery list for a high protein, high fiber diet, you will be shocked at the information that gets printed, that comes onto your phone and can ultimately be printed out. And so I think that artificial intelligence can really be used to help us make healthier choices when it comes to optimizing our diet. Similarly, ChatGPT is amazing for a question as simple as, what are examples of a high protein, high fiber diet in a Chinese restaurant? And you will see amazing choices to choose, or an Italian restaurant or a French restaurant. So it's a simple app that you can have on your phone that really can help you make better choices when you're shopping at Costco, when you're shopping at the grocery store, and when you're making choices at the restaurant. So other than increasing dietary protein, resistance training or learning to lift weights, utilizing a personal trainer, very important for building skeletal muscle mass. And the best ways to decrease fat mass is to exercise aerobically, walking, jogging, riding a bicycle, swimming, low-fat food choices, low-carbohydrate food choices. And I'm a really big fan of rucking. If somebody doesn't know what rucking is, it's excellent. Rucking is essentially walking, but you can take a JanSport backpack and put a 5 or a 10 pound weight in the backpack and walk. And I think that it kills two birds with one stone because you get your aerobic walking in and you also get your muscle building in by having the weight on your back. Because once you climb a little hill, you're going to feel that extra 5 pounds of weight in the backpack on your leg muscles. So rucking is if you like to walk, I think it's a great way to both decrease your fat mass and to increase your lean muscle mass. Because to say it again, it's not the number on the scale, it's about your body composition. So part of what we do during a consultation is I review your blood work and I will perform a bioelectric impedance analysis. And a bioelectric impedance analysis is an in-body test. And an in-body test, other than a DEXA scan, is really the gold standard of the state of the art for learning what your body is made out of. Why do we need to optimize skeletal muscle mass? I thought this was a lovely picture of the skeletal muscles covering all the bones. You could see how it's a protective soft tissue layer to prevent against fracture. Increasing skeletal muscle mass increases basal metabolic rate. What's that? The basal metabolic rate are the number of calories that you burn in a day doing nothing. So just lying in bed, watching television, doing nothing, those are the number of calories that you burn during a day. This can be measured with a bioelectric impedance analysis, and this is very important to know. Why? You know that if your basal metabolic rate is 1,200 calories a day, and if you're going to exercise and burn 500 calories a day, you know that you should consume 1,700 calories to keep the same weight. If you consume more than 1,700 calories that day, whether it be in the form of carbohydrate, fat, or protein, all of that excess consumed food that was not used by the body for energy will be stored as fat. So to know what your basal metabolic rate is and to have an idea of how many calories you're burning a day is important. Skeletal muscles, the fuel for skeletal muscles is glucose. So people who have a higher skeletal muscle mass have lower blood sugars. It keeps the skeletal muscle mass keeps our bones strong. It keeps us vertical. It keeps us moving, and it keeps us safe from injury. Body fat percentage. This is important because as the body fat percentage goes above 35 to 40%, that's associated with increased mortality. And mortality means you're more likely to die if you're at any age, if your body fat percentage is above 35 or 40%. So in a man, we'd like a body fat percentage to be around 15%. In a woman, we would like body fat percentage to be around 23%. And it's important to know that all fat is not created equal. There are two types of fat. There is the subcutaneous fat, which is the pinchable fat, and my cursor is on the subcutaneous fat, subcutaneous meaning underneath the skin. So this is the skin, this is the subcutaneous fat, and these are the abdominal muscles. So this out here is what you can pinch. And deep in the abdominal cavity lies the visceral fat. And visceral fat is the bad fat. The visceral fat is the fat that lines our organs. And what happens is, as I mentioned earlier, if we consume more calories in a day than we burn, first thing it does is that extra glucose will get stored as glycogen in our muscles and in our liver. And when the glycogen storage tank is full, then that glucose will get stored as subcutaneous fat. And when the subcutaneous fat gets full, that's when it spills over into the visceral fat. So when people that are obese, that have a lot of visceral fat, when they continue to expand their horizons and their waist continues to increase, it's because of increased visceral fat. So it's really important. The visceral fat is the important fat. It's the poisonous fat. And we measure visceral fat when we do bioelectric impedance analyses. So again, it's more important to reduce the visceral fat. This is the fat that causes insulin resistance, hyperlipidemia, high blood pressure, adult diabetes. The visceral fat is the most poisonous fat. And reducing visceral fat is the number one thing that we want to address. And we'd like a visceral fat level to be less than 100 square centimeters. Above 100 square centimeters puts somebody at increased risk for cardiovascular disease, sleep apnea, dyslipidemia, diabetes, insulin resistance, and hypertension. And the joint pain that's listed on there is because when you're carrying around excess weight in the form of fat, it's excess stress on the joints, where the joints that tend to get most affected are the hips, the knees, and the feet. Metabolic syndrome is when the waist, the circumference around the waist is larger than the circumference around the seat of the pants. So it's the waist to hip ratio being greater than 1. And as I said, the gold standard other than a DEXA scan would be a bioelectric impedance analysis. So what's that? An in-body composition analyzer is a device that you stand on. There's an electrode for your right foot, an electrode for your left foot. There are electrodes for your arms. You stand on the machine like the gentleman is over here with the arms away from the body. The data that the in-body machine wants is how tall you are and what's your gender. It does not take your age into account. So if you're a 5'6" male and you weigh 160 pounds, there's a healthy normal zone where if you're a healthy normal 5'6" male, there's a certain healthy weight zone that if you're above that, it's above normal. And if you're below that, it's below normal. And we can calculate this in the office before coming in for a consultation. It's definitely a good idea to hydrate yourself well the day before, to drink lots of liquids. It's a good idea to not come into the test on a full stomach because the in-body machine cannot tell the difference between body fat and undigested food in the intestine. And it's also a good idea to come in for an in-body composition analysis, body composition analysis, on an empty stomach and on an empty bladder. So we ask everybody to urinate before the test. Otherwise, it might measure too much extracellular water. So this is what an in-body test looks like. It looks complicated, but everything looks complicated until you understand it. So this is a 5'6" male. He weighs 164 pounds. Out of the 164 pounds, 94.6 pounds precisely of his body is equal to water. 35.1 pounds precisely is equal to fat. 73.6 pounds precisely is equal to the amount of mass that makes up his skeletal muscles. So as we go down to the muscle fat analysis, we like these 3 bar curves not to be in the letter C, but to be in the letter D shape. Let me expand upon this. The middle zone, this where my cursor is moving from right to left, this is the healthy normal zone of 5'6" males, period. And so since this is, let's say, at 120 percentile, that means that this particular patient is about 20% heavier than the average male of his height. His skeletal muscle mass is above the normal limit, which is good. So we want to maintain this or have it grow. And his body fat mass is 35%. Well, I'm sorry, is 35.1 pounds. So we'd like this bar to be closer to the 100% or the middle of the normal healthy zone. So my goal with this particular patient would be to drop his weight by dropping his body fat and by making sure that his skeletal muscle mass stays the same or increases. When it comes to measuring obesity, the BMI or the body metabolic index, it's not nearly as accurate as the percent body fat, because as I mentioned in the previous slide, if your percent body fat is greater than 35 to 40%, that's associated with disease. Body metabolic index, it does take your height and weight into account, but it doesn't separate the skeletal muscle mass that's good for you from the fat. So it's really I think, going to be an antiquated measurement, and I think percent body fat, which correlates better with disease than BMI, is going to be the new obesity analysis number moving forward. So what do we have over here? A percentage body fat of 21.4. Well, a male should be 10 to 20% body fat, so we want this particular patient to get somewhere in the middle, somewhere on the order of 15% body fat while keeping his skeletal muscle mass the same. I love the segmental lean analysis because the in-body of today, the bioelectric impedance analysis today, it breaks the body down into 4 quadrants: right arm, right leg, left leg, and the trunk. And so in this particular patient, there's precisely 7.12 pounds of muscle in his right arm, 7 pounds of muscle in his left arm, almost 20 pounds of muscle in each leg. And these percentages that are below the pounds have to do with the percentage that each of these limbs are able to sustain his weight of 164 pounds. So he has more than enough skeletal muscle mass to support his 164 pounds because each of these numbers are greater than 100%. The ECW to TBW ratio is extracellular water to total body water. This is also known as an edema ratio. When people have congestive heart failure or they have extracellular water, they tend to have swelling in their ankles at the end of the day, or they tend to have eyelid and facial puffiness in the morning. So we want the extracellular water to total body water ratio to be somewhere between 36 to 39%. And this is something that we measure on a monthly basis. The almighty visceral fat area. So this patient has a visceral fat area of 109, not bad. Under 100 is not associated with metabolic syndrome and the diseases that go along with it. So his visceral fat is good. When it comes to his fat-free mass that we can control, i.e. His body fat mass, he should lose about 12.3 pounds of his body fat mass, and that'll end up bringing his weight and his body fat mass down into the normal range where we would like it. The segmental fat analysis is interesting because it shows, like with most people, most of this patient's fat is in the trunk. And interestingly, not typical with men, we see this more in women sometimes. This patient has more fat in his arms than his legs and the most in his trunk. And so this is the type of data that we can get on a monthly basis to track how somebody's doing, to make sure that while they're on a GLP-1, on a peptide, on a program, a hormone replacement therapy program, that we're decreasing percentage body fat, increasing skeletal muscle mass, decreasing visceral fat, the bad fat. So again, this is the next era of obesity medicine. It's a two-way street, so I encourage everybody to continue with regular exercise so you can burn fat. We want to preserve or build lean muscle mass. We want to promote a high protein and a high fiber diet while minimizing carbohydrates. Let's just talk about carbs. Carbohydrates are broken down into glucose. So if you eat a Jolly Rancher, that's very close to glucose. So blood sugar levels spike very quickly after eating sugar. Why is this bad? Well, the inside of the blood vessels don't like it when the blood sugar is very high. And when the endothelium or lining of the blood vessels get damaged from blood sugar being too high, the organs that tend to get damaged are the heart, the eyes, the kidneys. And this is why it's very, very, very important to decrease visceral fat. Other than doing a bioelectric impedance analysis before you meet us, we will send you a prescription for blood work. We check a complete blood count and a ferritin level, especially in women. I am shocked to see how many women that have normal hemoglobins have ridiculously low ferritin levels. A ferritin level is our iron storage in our body. And the most common cause for a low ferritin level in a menstruating woman is frequency of menses, number of menses, or the severity of the menses. Women that have more blood loss on a monthly level are more likely to have low ferritin levels. If people have a ridiculously low ferritin level, that's associated with very low energy, brittle nails, thinning hair, feeling cold all the time, very hypothyroid symptoms. And by supplementing ferritin or by getting iron storage up to normal, people's energy comes back ridiculously quickly. We check for thyroid function testing because low thyroid function decreases our metabolism of fat. So we want our thyroid optimized. We like a free T3 level to be between 3.5 and 4.2. And we look at hemoglobin A1C. What in the world is hemoglobin A1C? Hemoglobin is the molecule that's in our red blood cells that makes them red, and it's the molecule in our red blood cells that carries oxygen. As a matter of fact, when oxygen binds onto hemoglobin, it becomes bright red, and when the hemoglobin is deoxygenated, it looks like venous blood. It turns it purple. So what's A1C? Hemoglobin A1C is glycosylated hemoglobin. What does that mean? Well, when we have high levels of glucose in the blood, not only does it affect the organs negatively, it also affects our red blood cells, and it glycosylates the hemoglobin, or the sugar or the glycogen, the glucose gets stuck to the hemoglobin, and that can be measured. So hemoglobin A1C is an excellent measure of how our blood sugar is doing for most of the day, for most of the time. And so hemoglobin A1C is very important. We like a fasting insulin level. We like fasting insulin levels to be less than 10, preferably less than 7. I check a vitamin D and vitamin B12 level on everybody. Why? Remember, one of the 4 components of our body is calcium in the bones. And if vitamin D is low, and I'm going to say low vitamin D is endemic in America. I don't think I've met a patient that has a normal vitamin D level that's not taking a supplement, and I'm serious. So we optimize vitamin D to be closer to 70 to 100 as opposed to closer to 30 to 40 to ensure that the dietary calcium is being properly absorbed into the bones so that your bones remain strong, so we remain vertical and mobile and moving. The vitamin Bs and vitamin B12 is an energy vitamin, so we check for that. And when we're dealing with perimenopausal women, postmenopausal women, men that are over 40 that don't have energy, we check the sex hormones, which are testosterone and estradiol, and we also check sex hormone binding globulin, because in some people this binding protein can be very high and can cause what appears to be normal testosterone levels to be actually less than normal free testosterone levels. So let's get into the good stuff. The 2 GLP-1s that we prescribe are semaglutide and tirzepatide. The brand names of semaglutide are Ozempic and Wegovy, and the brand names of tirzepatide are Mounjaro and Zepbound. They're both GLP-1 agonists. Semaglutide came out first. What's an agonist? I know that we all know what an antagonist is, somebody that antagonizes us or bothers us. An agonist is something that helps the situation. So a glucagon-like peptide agonist is going to be several amino acid chain worth of peptide that resembles glucagon and is going to function like glucagon, which is a hormone that's produced in the alpha cells in the islets of Langerhans of the pancreas. And this is, it's wonderful how it works both on the brain and on the gut and on the heart and on the kidneys and on the brain. This is why I think it's revolutionary. The number one mechanism of action of the GLP-1s, in my opinion, is on the brain by decreasing appetite and decreasing cravings. So there is going to be, in my opinion, a role for this in addiction medicine. It decreases cravings for alcohol. It probably decreases cravings for other addictive substances also. It certainly decreases cravings for food, and it decreases the amount that you'll eat because it decreases gastric emptying time also. So we tend to get fuller faster. So these are the two GLP-1s that we're very comfortable with and we prescribe on a regular basis. This slide is a bit complicated, but it touches on the revolutionary effects of GLP-1s, okay? So yes, it works on the brain to decrease cravings. Additionally, there's data that's coming out that shows it's protective against Alzheimer's disease. So if there's Alzheimer's disease in the family, taking a GLP-1 is not going to hurt. That's for sure. So as we decrease less food, GLP-1s also work on the gut in the stomach. It decreases absorption of free fatty acids and lipids from our diet. And it also decreases our blood sugar by increasing our serum levels of insulin, which gets the blood sugar out of the bloodstream and into the muscle cells. Interestingly, GLP-1s have a direct effect on the kidney. They promote diuresis. They promote natriuresis, which means the excess urination that you do, you're also going to lose excess salt in your body, which has a blood pressure lowering effect. There's cardioprotection. GLP-1s have been shown to decrease heart attack and stroke, and they also thin the blood. They're platelet inhibitors. When they're well tolerated and given in a proper dose, in my opinion, they're revolutionary. So what exactly are we prescribing? We're not prescribing Ozempic and Wegovy. We're prescribing semaglutide, which I purchase all of my GLP-1s from the BioT RX compounding pharmacy called Innovations. It's excellent, very high quality. And it's important to say this is not FDA approved. And I'm going to make some arguments later on as to why I believe the non-FDA approved approach utilizing a compounded GLP-1 is a better approach. It's a better approach as long as you're getting good product. And that's all that we deal with here. So again, the semaglutide enables easier weight loss by decreasing appetite by 50% and increasing satiety after meals, lowering hemoglobin A1C, lowering risk of a cardiovascular event. The newer peptide, tirzepatide or Mounjaro or Zepbound, it's special because it's not only a GLP-1 agonist, it's a GIP agonist. GIP is glucose-dependent insulinotropic polypeptide. Say that 10 times, I dare you. The fact that it's a GIP agonist and a GLP-1 agonist means it may be a bit stronger than semaglutide, but I'm not sure of that. It certainly is an alternative. There are fewer doses, so it's easier for me to titrate somebody to the sweet spot, where the sweet spot is 50% appetite reduction and early satiety. There are studies that are showing it's possibly superior to semaglutide for weight loss. It possibly has fewer side effects like nauseousness, constipation, rarely diarrhea, upset stomach, and reflux. So tirzepatide is possibly better tolerated than semaglutide. And there's one thing for sure, tirzepatide is more expensive. Just to put things into a ballpark as to how much does this cost. I would say a maintenance dose, a weekly dose, this is injected weekly. Peptides, GLP-1 agonists are injected by yourself weekly. Semaglutide is something on the order of $20 to $40 per week, depending on your dose, and we do not mark up the price of our drugs. And tirzepatide is something on the order of $30 to $90 per week, depending on your dose. So there's a big price difference. So if prices and the reality is, so which is better? Which is better for the treatment of obesity? And the answer is the one that works. I've listened to the experts lecture on this, and the experts call semaglutide and tirzepatide different flavors of ice cream, which means either one can work better on one person than another person. We have seen responders to a starting dose of semaglutide, quarter milligram of semaglutide, and the maximum we go up on semaglutide is to 1.5 milligrams. We've seen responders to a starting dose of tirzepatide or 2.5 milligrams. So it's a little easier to titrate somebody with tirzepatide to get them to the sweet spot where they're really feeling like, I'm not hungry right now. This is amazing. Or perhaps I don't want to have another drink tonight. It's going to make me fat. Makes you think differently. Very interesting medication. This is I'm going to use this to describe what we do differently than what the FDA approved guidelines are for the use of semaglutide. So if you were to get, this is the package insert from Norvo Nordisk, Wegovy's product. They want to keep people on a quarter milligram for a month, then a half a milligram for a month, then 1 milligram for a month. And there's really nothing wrong with that. That's relatively conservative. The problem is going from 1 milligram to 1.7 milligrams. It's too much. It's too much of a jump based on what I've seen so far. It should go 1 milligram to 1.2 milligram, 1.25 milligrams to 1.5 milligrams. They're missing a step over here. And then they go from 1.7 milligrams to 2.4 milligrams. That's another huge dose that increases the risk of side effects for patients. They'd like everybody to be on a maintenance dose of 2.4 milligrams so that they should make the most money. And we never prescribe a dose this high. The highest dose we've had to prescribe of semaglutide is 1.5 milligrams. In fact, if somebody is not responding to 1.5 milligrams, I would start to think, why aren't they responding to it? So one of the advantages of having a compounded product is it gives you and me the ability to vary your dose so we can give you the lowest possible dosage to get you into the sweet spot, where the sweet spot is I'm not hungry, I'm losing weight, and I'm full early. So the other disadvantage of these injectable pens, as you've seen on television, these come in preloaded syringes. If I wanted to give somebody, if I prescribed a 1.7 milligram pen and wanted them to only take 1.25 milligrams, it's impossible to do that. So it does not give the physician nor the patient the flexibility to get to the lowest dose possible. And, from a technical standpoint, when you take these pens and put them up to your skin, there's a propensity to push them down as hard as you can because you don't want to waste any of the medication. And when you press the button, the needle ends up going in a bit deeper. So it's a more painful injection and there's a little bit of a higher risk of bruising. That's my least important concern about the pens. My most important concern about the pens is the fact that it decreases the ability of you and me to moderate to the lowest possible dose that's effective. Similarly with tirzepatide, they do 2.5 milligrams a week for a month, and 5 milligrams for a month, and 7.5 for a month, and then 10 milligrams for a month. And then they want to get everybody on 15 milligrams on a weekly basis. We've never had to prescribe 15 milligrams for anybody. And the other thing that I didn't mention on the semaglutide that goes for both semaglutide and tirzepatide is we increase the dose every 2 weeks, not every 4. I started doing every 4 weeks. It's unnecessary. So if somebody is tolerating 2.5 milligrams for 2 weeks and they're not losing weight and they don't have early satiety, then we go to 5 milligrams. And so our therapeutic window for tirzepatide is between 2.5 milligrams and 10 milligrams. The majority of people are seeing an effect on 5 to 7.5 milligrams, some 2.5. This is a very strong and good peptide. So ideal candidates for GLP-1s are people that have elevated body fat percentage or too much visceral fat, because these two entities lead to disease. Again, cardiovascular disease, non-insulin dependent diabetes, hyperlipidemia, hypertension. These people with elevated body fat percentage or visceral fat that want to lose weight, excellent candidates. If there's insulin resistance, adult diabetes, elevated hemoglobin A1C, arthritis in the lower extremities, or even addictive tendencies, that is going to become more the norm than the exception based on what's coming out in the literature. Interestingly, GLP-1s have been helpful for female infertility. And they're also helpful for women with polycystic ovarian syndrome, which is, I think, revolutionary unto itself. PCOS is a very common condition where some women have a very hard time losing weight that have PCOS. And part of the polycystic ovarian syndrome has to do with a woman's adrenal gland making a bit too much androstenedione, which is ultimately a precursor for testosterone, which ultimately in some women can cause excessive hair growth and acne. And there's also a propensity for difficult time losing weight. And the GLP-1s are just really helpful for polycystic ovarian syndrome in getting people's metabolism and body composition back to normal. Who shouldn't use a GLP-1? There are always exceptions to the rules, but the rules are if there's a history of gallstones, pancreatitis, kidney disease, liver disease, if you're pregnant, if you're breastfeeding, no GLP-1s. Gastroparesis, you would know it if you had it. Gastroparesis is a condition where the stomach just naturally doesn't empty normally. It empties slowly. Gastroparesis can be a side effect if you take too much GLP-1, which is why we like to keep the dose as low as possible. If there's gastroparesis, I would hesitate on giving a GLP-1 because we don't want to make a pre-existing condition worse. You've probably heard this on TV, medullary thyroid carcinoma or multiple endocrine neoplasia syndrome type 2. This was only seen in rats, not in humans. If somebody has a prior history of an eating disorder like anorexia and bulimia, I would probably have second thoughts about giving a GLP-1. The side effects, as I mentioned earlier, nauseousness, constipation, heartburn, sometimes diarrhea, rarely a headache. How do we deal with this? First thing we do is increase fluid intake. I might prescribe a bit of ondansetron or Zofran. It works very well for GLP-1 induced nausea when it happens. And if it's severe, we go down on the dose the next week because the side effects end up going away. So side effects get less with time, but this is a slow and steady course where the doses have to be increased very slowly and very incrementally to keep the side effects to a minimum or to zero. And as I mentioned earlier, polycystic ovarian syndrome, female infertility, Alzheimer's disease, heart disease, and addiction unto itself. This is the future of GLP-1s beyond the benefits of weight loss. Well, the GLP-1s are not the only peptide that we have in our toolbox. The third one I'm going to talk about, which is really a neat peptide, is called sermorelin. And sermorelin is human growth hormone releasing hormone. That's another big one. So what does that entail? It's injected 5 nights out of the week. So 5 out of 7 nights at night, you give yourself an injection under the skin, same type of injection as would be with semaglutide or tirzepatide. And what it does is it increases your brain's production of growth hormone while you're sleeping. Anecdotally, I've seen that it improves people's sleep. People tend to fall asleep better when they're taking sermorelin. It can be a mood enhancer unto itself. It may stifle the appetite a bit, and sermorelin is definitely helpful for promoting the formation of lean muscle mass and losing percentage body fat and losing visceral fat. As a matter of fact, out of the 2 peptides, it's starting to show it's possible that tirzepatide is better than semaglutide at decreasing visceral fat. They both decrease visceral fat, just which one is better. So sermorelin is another peptide. So who would take sermorelin? Somebody who's lifting weights that wants to optimize a bodybuilder that wants to optimize their skeletal muscle mass and become ripped, because by increasing the secretion of growth hormone from the pituitary gland, it's definitely increases lean body mass and decreases percentage of body fat. People tend to see results from Sermorelin as soon as 2 to 4 weeks after starting. I think people start to see improved sleep immediately after starting. And it's excellent for protecting against muscle loss from a GLP-1. So if I see somebody that wants to lose weight that has decent muscle mass, but a very high percentage body fat and elevated visceral fat, I might start on a GLP-1. Once they have them come back in a month and put them back on the end body, once I see somebody is starting to lose skeletal muscle mass and they're starting to jeopardize their skeleton, their musculoskeletal system that keeps us vertical, keeps us erect, keeps us moving around, it keeps us burning calories. Sermorelin is excellent for protecting against muscle loss. It has very similar effects to that of testosterone without the side effects of testosterone. The fourth peptide I'm going to mention is glutathione. Glutathione has been around forever. We've been giving glutathione intravenously in the form of a hangover drip and in the form of a immune boost drip. Why? Because glutathione, number one, it's a free radical scavenger and it helps to remove toxins from the body. So that's part of the active ingredient in our hangover drip, to get the toxins out of your body. And it's also an active ingredient in our immune boosting IV drip because it bolsters the immune system. So glutathione, if Dr. Myers, who invented the Myers cocktail many moons ago, if he were around today, he would condone the use of glutathione in his cocktail. The other interesting benefit of glutathione is it's excellent for skin lightening due to post-inflammatory hyperpigmentation, other forms of hyperpigmentation, or melasma. So glutathione is also given topically, typically with vitamin C in a cream for the sake of lightening the skin and reducing brown spots on the skin. The last peptide I'm going to discuss is a combined peptide. It's BPC 157 and KPV. It's a gut peptide, and this is really all you need to remember. If somebody is having constipation and they can't seem to find a remedy for their constipation, BPC, KPV, along with the probiotic, can be helpful. If people are having reflux or heartburn and they can't seem to get it under control, BPC 157 and KPV may be helpful. Both of these peptides have also been shown to be helpful in recovery from soft tissue injury and wound healing. So we recommend BPC, KPV in all of our surgical patients that we operate on because it's helpful for wound healing in our surgical patients. Pearls for success. We're getting close to the end. We want to get somebody, when we identify somebody that wants to lose weight, that has a percentage body fat that's too high, we're probably going to reach for a GLP-1, provided that their skeletal muscle mass is normal or high or not too low. And our goal is going to be to prescribe the lowest dose of a GLP-1 that provides 50% appetite reduction and early satiety. I encourage all of our patients to focus on nutrient-dense, high-protein, high-fiber foods, low-fat, low-carbohydrate foods. And why? Because when you get into the zone, when you're into the sweet spot where you're not hungry, you also tend to not drink. So there is a propensity, which is why some people can get sick on these GLP-1s. If they're on doses that are too high and they're having too many side effects and they're not eating enough, you can end up going from too heavy to unhealthy by losing too much on the way of skeletal muscle mass and overall weight and become sarcopenic. So nutrient dense food, changing what you eat, single ingredient foods, as will come up if you use ChatGPT. And when I say single ingredient foods, in the beginning, are processed foods the enemy, or are they the cause of obesity in today's society? And I said yes. It is more expensive to go to the supermarket and to buy a piece of chicken and to buy a piece of broccoli and to buy sweet potatoes and to cook them than it would be to go into the frozen food section. Okay. So a single ingredient food is the other way to look at it. Nuts in the form of almonds, walnuts, nuts, legumes, terrific. Single ingredient, high protein, high fiber. Broccoli, any vegetable you want, lettuce, salad, single ingredient foods, turkey, chicken, fish, single ingredient foods. Box of cereal, don't do it. Pancakes, waffles, special occasions only. So nutrient dense foods, people that go on GLP-1s with proper guidance and proper exercise, this is definitely a two-way street. It's not a silver bullet, but it's close. People can lose 15% reduction in body weight, and we're talking about healthy body weight, body fat. We want to add resistance exercise, which is something that I did not used to recommend as much as I do now until I learned what a healthy organ skeletal muscle is. And by having a big skeletal muscle organ or having big skeletal muscle in our body, we decrease our blood sugar, we decrease risk factors for a lot of disease, keeps our bones strong, and we lead a longer, higher quality, more healthy life. High protein, high fiber diet, drink more water than necessary, at least 2 to 3 liters of water a day. The other way to know that you're drinking enough water is to really bring to work 2 to 3 liters of water. And once you start urinating and your urine becomes clear, that's a good indication that you're well hydrated and that your kidneys are flushing all of your toxins out and that the tank is filled with water. And a monthly bioelectric impedance analysis while people are losing weight so that we can do this in the safest possible fashion to increase people's longevity, increase the amount of time that they're vertical and moving, and to overall increase quality of life. So I really appreciate everybody taking the time to listen to this presentation, and I encourage and welcome any and all questions. Nancy, how are we doing on questions?
You're doing fantastic. Let's see here. That was wonderful. What a wealth of information and education for your patients. If someone is interested, what would be the next step for them to
Uh,
contact?
I would say go to njhealthandwellness.com and scroll through it. Our main landing page talks about our bioidentical hormone replacement therapy. We use only BioT products. And there's also a page on peptides, and there are videos at the bottom of each page. I would start by going there. And when you're ready to pull the trigger and come in, just give our office a call and make an appointment for a therapeutic wellness visit.
Right. Let's see here. You mentioned lab work.
Yes.
How does that work?
We will email a prescription for blood work to anybody who inquires for it. So that's how it works. We'll get
Okay.
an email address and we email a prescription. And then you would go to your local LabCorp or Quest or other laboratory that participates with your health insurance and get your lab work done.
Okay. Great. Another question. Do you have to stay on this forever, or if you stop, will you gain weight?
I get this question all the time, so whoever asked it, thank you. No, you don't have to stay on it forever. The goal behind all this is changing our bodies to a healthy body composition. So once somebody gets to the healthy body composition, what do you do? Well, the wrong thing to do is to go cold turkey and stop. Okay, the wrong thing to do is to go cold turkey and stop. So let's say, as an example, if somebody's in the zone at 5 milligrams of tirzepatide, where we're at 50% appetite reduction. We're losing 2 to 3 pounds on a weekly basis. We feel like it's working. We're not having side effects. We do an in-body exam, and all of a sudden, wow, we're there. I'm at my goal. What do we do? Well, the first thing I would do is go from 5 milligrams to 2.5 milligrams for 2 weeks. And then you answer the question, have I gained weight? If no, then 2.5 milligrams is the starting dose. Then you stop. And then you go 2 weeks. Have I gained weight? If no, you're there. If you start putting on weight, we can always reintroduce a GLP-1, because if you remember several slides earlier, the benefits of being on these medications greatly outweigh the negatives of not being on them insofar as longevity goes. The only reason why people will voluntarily not want to take GLP-1s is because of price, because it's too expensive, or if they're having side effects that just can't be overcome. And that's unusual.
Great. Perfect segue to the next question. How much do all the initial tests cost?
Our consultation fee is $200, so it's a $200 consultation fee. That includes the in-body bioelectric impedance analysis. Follow-up visits are $100 and include a body composition analyzer. The medications, I discussed the fees of them earlier. That is essentially on the patient to pay for, which is ridiculously less expensive than the brand name products. The brand name Ozempic, a starting dose of Ozempic out-of-pocket fee is about $1,200 a month. A starting price semaglutide, same thing, fee is about $80 a month or less. So there are magnitudes of difference in the price. So to answer the question, no, you don't need to be on it forever. When body composition goals have been reached, we wean off of it or wean down to the lowest possible dose to maintain the healthy composition.
Great. Someone said, thank you for the excellent presentation. They will call to schedule an appointment. That's wonderful. Next question, why are these not FDA approved? That makes me nervous.
Oh, well, it doesn't make me nervous because I've been doing this for 25 years and I've been dealing with off-label usage of FDA products for the entirety of my career. We all do it as doctors. What's interesting about semaglutide and tirzepatide, which I've not seen before, is the reason why compounding pharmacies are able to make semaglutide and tirzepatide is because the companies, Eli and Novo Nordisk, they can't keep up with the demand. So there's more prescriptions that are being written for these peptides than the drug companies are able to provide. So I understand that there's some sort of mental well-being that goes along with getting a brand name medication as opposed to a compounded drug. But BioT, if you do any research into the company, deals with only the best of the best when it comes to purity and quality. And that's been our experience and the experience of our patients. It's absolutely been well received by those who have benefited from
it. Next question. All docs prescribe meds off-label. I guess that was a comment. Are you aware of any serious side effects from these drugs?
As I mentioned earlier, the common side effects that can be a nuisance for somebody is nauseousness. If it's severe, it can be vomiting, usually not for a whole week, but nausea, vomiting, constipation, rarely diarrhea, and reflux. That's it as far as complications that I've seen. Insofar as cholecystitis, gallstones, inflammation of the gallbladder, and pancreatitis, these are very, very, very uncommon side effects that can happen. And when you talk to the experts that have done thousands of these, Most haven't seen one case of those. So I will argue that GLP-1s and peptides are ridiculously safe. As a matter of fact, there are millions of people right now that are on compounded peptides, and I'm not aware of one death. So,
Interesting. And I believe this is the last question. How soon can one expect to start losing weight?
great question. We have had responders on a starting dose. So there are some people that respond to either 0.25 milligrams of semaglutide or 2.5 milligrams of tirzepatide, and that's where they stay. So this is why when I start to titrate somebody, when I meet somebody and get to know them, the visits are more frequent in the beginning until we find the sweet spot. Once we find the sweet spot, people disappear for several months as opposed to a monthly visit. So weight loss can happen as soon as starting, or the real answer is as soon as you get to the lowest dose that brings you into the zone. And with semaglutide, that tends to be between a quarter of a milligram and 1.5 milligrams. And with tirzepatide, that tends to be between 2.5 milligrams, 10 milligrams the max, 2.5 to 7.5 milligrams most common.
Okay, it appears that that's it for the questions. Anyone else with a question out there? Let's see here. 3. Nope, we answered all 6 questions.
Great.
I think that's it. That was a wonderful presentation, Dr. Joseph. We greatly appreciate you taking the time to offer this to your patients. It's priceless for your patients. I hope they call you as soon as possible and schedule that consult to have a beautiful quality of life and live healthier as they age, for sure.
Nancy, God bless. Thank you, my dear, and thank you to everybody in the audience. We hope to meet you soon.
Thank
Take
you,
care now.
everyone. Good night.
Bye-bye.